Welcome to Halteres Presents, a brand-agnostic interview podcast that seeks to objectively highlight the happenings within the world of diagnostics. And now, your hosts, Rich Thayer and Mickey Urdea.
Hello and welcome to another episode of Halteres Presents. This is Mickey Urdea, founding partner at Halteres Associates.
And this is Rich Thayer, managing partner at Halteres. Today we are interviewing Dr. Jennifer Nuzzo. She's professor of epidemiology and the director of the Pandemic Center at Brown University School of Public Health. We had a fascinating discussion about the current state of public health in the United States, the critical role of testing and diagnostics, and lessons learned and what maybe we could do better in terms of being ready for the next pandemic.
In our interview with Dr. Jennifer Nuzzo.
Well, hello, Jen, and thanks so much for joining our podcast. We're pleased to have you as our guest. Please tell our listeners a bit about yourself and your work and your efforts at the Pandemic Center at Brown University.
Thanks so much. Thanks for having me. It's a great privilege to join you. I'm excited for this conversation. So I'm an epidemiologist by training, but I work really more on sort of policy and practice. I do sort of operational research. I'm in this kind of niche field called health security, global health security. And essentially we're looking at the intersection of when health events are not only just health events, but they also potentially can become national security events. And, I sort of got my start in this field more than 20 years ago, sort of following the events of September 11th. And, since then we've really borne witness to a number of different health emergencies, a couple of pandemics and a few epidemics and some really concerning outbreaks along the way. So lots been done, but a lot more work remains.
Well, you were very active in the public health response during the COVID-19 pandemic, and perhaps even more so post-pandemic to understand what we did well and, well, not so well. What are some of the major lessons that were learned?
COVID was really quite a alarming situation. I mean, obviously it was alarming for everyone who went through it, but for someone who's thought about pandemic preparedness, thought about what it would take to get ready for it, was involved in sort of measuring countries' readiness. I mean, I was in no way prepared for how much of a struggle it would be, even for highly prepared countries like the United States. So for me, it was really a wake-up call that we needed to rethink what it means to be prepared for future health emergencies like pandemics. In many ways, I sort of wanted to kind of start from scratch and rebuild and not just try to tweak the existing systems. But I think a lot of the challenges were that we failed. I mean, they really stemmed from a few things. On a technical level, our original sin in responding to COVID-19 was not quickly establishing an adequate surveillance system, and crucially, the role that testing plays in supporting that surveillance, so that we knew what was happening and then could act and respond accordingly. So that was, I think, our big technical challenge. But I think we had a larger strategic challenge, which is that we didn't fully recognize in our response to COVID that it was going to be a pervasive and protracted event. When everything shut down in March, I think many people very happily retreated into their homes. They didn't love the fact that their kids couldn't go to school, but they understood, that it was for the greater good. And they were expecting to do that for a couple of weeks. And then maybe there was an expectation that we could just go back to normal and the virus would be gone. But that was really never a realistic assumption. And I don't think we adequately prepared for, as a society, but also as, in an official response, an event that was going to be over the long term. And what did it mean to respond to COVID, given that the virus wasn't going to go away, that all the measures to kind of slow the spread were really pause button measures, that if you stop doing them, the virus spread would pick up again. And I think that if I had to kind of quickly summarize all of the missteps, I would say it was that failure of strategy.
Do you think we'd make the same mistakes again in the future?
The optimist in me will say, listen, we just all went through something completely profound. We lost more than 1 million American lives. COVID has affected all of us in myriad profound ways. I think in many ways, we as a society better understand what these events mean. And even though we're determined to try to forget that COVID happened, we like to argue with each other about how bad it was. I think we have some knowledge that is hard to undo. Right? We know that these events can be profound, that it can have a lot of loss of life. We also know that there are steps that we can take on a national level a local level and even on a personal level to try to protect ourselves. And I think that knowledge is really key. So my optimistic take is that we are better in a number of ways. I think politically, though, I am quite worried. I really expected that after an emergency that killed upwards of 1 million American lives. I mean, we're approaching, we've far exceeded that now, but after something so profoundly bad, I thought for sure we as a nation would, put our heads together and say, wow, that was really terrible. How can we make sure that never happens again? Certainly, as someone who got my start in this field, in the aftermath of September 11th, when we lost 3,000 American lives, and saw the kind of initial, bipartisan support to improve our systems and audit our responses and to ask the tough questions so that we never had to ask them again. I thought for sure that was going to happen. And the fact that it hasn't happened leaves me very, very worried, because some of these things are quite fixable. They're not, there are many points in which we as Americans disagree. But I think some of the points that we would likely surface in a really thoughtful analysis of what went wrong are fixable things on which there is no disagreement. And we're not going to be able to make those changes unless we, fully commit to confronting it and understanding what it is. And the lack of interest in that is really worrying to me.
We've heard from many of our global health colleagues that one of the downsides, perhaps, that has come from out of the pandemic is an increase in nationalism. How is that impacting your ability to run the pandemic center and to gather information that may be impactful in determining whether or not there's an outbreak or a pandemic?
I understand where this nationalism is coming from. After you have gone through a profound event that has upended our lives, after, many families have struggled, the cost of living is very high, it's very expensive. I understand at a political level why it may seem advantageous to say, we have to focus on ourselves. We have to focus on America first. That is always the responsibility of an elected official. Your primary responsibility is to the people who elected you. I think where the problem is that people are failing to realize that what it truly means to put America first, to protect Americans. And when we're talking about infectious diseases, that requires, there simply is no alternative to a global response. We, as Americans, have been really instrumental in building up crucial programs across the world, building up the WHO, building up national health agencies. That has been, by and large, beneficial to the health of the world. But it has also been exceptionally beneficial to the United States of America. I don't think many people understand that global health programs at CDC started in part because US businesses that were operating in other parts of the world needed to be able to do so safely. They needed to be able to do so effectively, and making sure deadly diseases didn't get in the way of that was critically beneficial. It also improved local health there locally, but it also helped improve American prosperity. So I don't think the fight is really over whether we should protect America. I think the disagreement is over the right approach. And I'm telling you, if you look at these diseases and if you look at these events, you realize that they don't stay put. What starts in one place, particularly in our highly interconnected world, will be around the globe very, very quickly unless we stop it. And that the cost-effective response is to try to detect it early and to contain it locally. It's also the response that helps grow economies, including our own. So it's as much about protecting our security, being secure from these deadly disease threats, as it is improving our economy. Controlling disease threats is important for American prosperity, as it is about promoting American health, which it very much certainly is.
Yeah, that's a great answer. Turning to another topic just briefly, we've heard that a large percentage of professionals working in the public health space have either retired or left public health since the pandemic. What can you tell us about the public health landscape in the United States today?
Yeah, I'm deeply worried on a number of fronts. It started with the pandemic. I think a number of public health professionals really got burnt out because they were operating around the clock, making really tough decisions under really stressful circumstances. And quite understandably, not all of those decisions were necessarily the right ones, and they were also not necessarily popular ones. I do believe very strongly that by and large, it was a lot of people trying their best to do the best. But nonetheless, I think a lot of people felt a lot of grief and abuse and criticism and frankly danger directed at them as a result of the tough decisions that they had to make. So we saw a lot of experienced public health professionals sort of leaving public health agencies around the US starting during the pandemic. In some cases, they were forced out when their political leaders realized that they were taking heat for the response. I will just say as an aside, political leaders are the ones that are ultimately bear the responsibility for what happens because they are elected to make the decisions about what should be done. Public health professionals, scientists can only offer advice based on what the data show, but it is ultimately the political leaders' responsibility to make the tough call. Nonetheless, I think it was very easy to hold up the scientists and the experts as the scapegoats. And so a lot of people left. And then what we then saw happen was, a series of, loss of funding in some instances that made people have to leave. And then I think the biggest upheaval that we have seen to date has been the effort to really shrink federal agencies, health agencies in particular, and in a very, very, in my view, not a nuanced or strategic or carefully, guided way. If you want to kind of look for efficiency, you'd think about using a scalpel. Instead, we've seen this very kind of capricious, in some cases, one hand not knowing what the other hand is doing, wholesale layoffs of entire units of government agencies. And we've really seen a departure not just in terms of thousands of qualified professionals and technical experts from government agencies, but crucially people who have experience in knowing how government works and how to get things done during emergencies. And the loss of that sort of operational knowledge and experience is the thing that I actually worry the most about. I would say, just holding up one example, is the CDC. I mean, the number of and the quality of people that have been lost over the last 10 or so months is deeply alarming. These are people in many instances that help set up centers for disease control in other countries. I mean, like the world's top experts in terms of governmental public health, who are now no longer working in service of the American people as part of the US government. And so I am really, really worried. I can think of no greater asset to the health, security, and prosperity of America than qualified, technically proficient, experienced public health experts working in our health agencies.
Just was thinking to myself about some of the people we've interviewed in public health over the last years, and then making sure we realize it's rarely testing that alerted healthcare officials to the presence of a potential threat. It was more often very astute physicians who did.
Yeah.
And if they heard that several times within a particular area, they'd say, we better look at this.
Yeah. Can I push back on that a little bit? Because I think those two things go hand in hand.
Yeah.
And here's why. Yes, it takes an astute clinician to say, this patient, there's something unusual about this. But they don't know what the this is until they order the test.
Right.
And that test is really key to confirm that, yes, it is in fact unusual, and then to tell you how big a problem it is. So I think that you need both. You need the astute clinician to say, I want to look into this further. But unless they have the tools to do that, it's going to be very hard to act, and you'll lose a lot of time. I mean, and I think of what happened in COVID-19, where there were clinicians who saw, hey, we have a strange number, this I'm talking about in China, who said we have a strange number of people with, atypical viral pneumonia. And, a number of them seem to have some connection to the seafood market. That's enough to say something might be going on. But until we got the test that said that it was a novel coronavirus, the response is sort of in this, well, wait and see mode.
Yeah.
We're aware of the unique set of people and skill sets at Brown now studying how to prepare for the next inevitable pandemic. It's such an impressive team. What are some of your major projects underway by you and your colleagues?
Well, thank you. Thank you for that. Yeah, I'm really grateful for our team and sort of proud of what we've been able to build in a few short years. It's a great group, and also proud of the fact that we have lots of collaborators outside of Brown. That was one of the things that we said from the beginning. Like, listen, we're not gonna, no one entity is capable of taking it all on, and the only way we're going to make meaningful progress on these issues is if we work together with others. So we have a very strong commitment to collaboration and just kind of synergizing efforts with other work that's ongoing. One of the reasons why I came to Brown to start the Pandemic Center was because it was clear to me in sort of watching the bloodbath that was COVID-19 and seeing how we got so many things wrong about that response, recognizing that a lot of the challenges weren't the traditional medical and public health challenges. Certainly those challenges were there. But a lot of the biggest challenges that the country, the globe wrestled with were social, political, and economic. And, as a faculty member of a school of public health, I could continue to kind of look at my little narrow slice of the expertise world and say, well, I'm just going to focus on it through this lens, or say, recognize that if we want to make some progress, we have to broaden the aperture a bit and avail ourselves of the expertise of other disciplines and bring them into this, because this is an inherently multidisciplinary challenge. Thinking about pandemics, biological emergencies, they touch all of health and they touch all of society. And so we need to bring in other disciplines as well. We've worked on a lot of different projects. One of the first ones that we worked on, maybe of particular interest to your listening audience, was to develop a testing playbook for biological emergencies. And this project really stemmed from the fact, so before I came to Brown, I was at Johns Hopkins and I was part of the team that was monitoring some of the COVID data. And specifically, I was kind of in charge of the portion of the COVID tracking site that looked at testing trends in the US and globally. So I was spending a lot of time looking at those data, trying to understand the question, are we testing enough? And how does our approach to testing influence what we even know about COVID in the United States and abroad? So I got a lot of questions over the course of the pandemic about COVID data, COVID testing, a variety of other things. And there were a ton of challenges. I mean, I'm not the only one to say this. I think many people acknowledge that our inability to rapidly establish and scale testing during the pandemic was probably the original sin in our response. It probably led to closures in parts of the countries that had no business closing because they probably had very little or next to no COVID. It probably was why we had so many deaths, because we were unable to protect our how much of our population lives in nursing homes, and a very exquisitely vulnerable population. We weren't able to inform people's decisions about how to gather safely, or how to isolate patients. I mean, there's so many different operational ways in which not having appropriate testing hindered our response and basically made us have to respond blindly, not really knowing what was going on, rather than sort of precision response that was informed or driven by data. Had we had better testing capabilities, we could have made more nuanced decisions. But everybody knew that COVID was a challenge when it came to testing. Everybody knew that we didn't get testing right. I mean, there were so many different reports about that, and one of the reports was a great one that the New York Times did that looked at the initial decision-making around testing and COVID and found that it was a blip in the bullet points that the COVID task force considered. A highly technical issue like testing was discussed and dealt with in like just a matter of a few minutes. Clearly not sufficient attention to what is a very complex and highly technical issue. So I thought for sure, again, coming out of COVID, that we got why testing was so bad, and that we were going to make sure we were never going to make those mistakes again, and that we would allocate appropriate decision making to the notion of testing the next time a biological emergency happened. And then with the Mpox outbreak in 2022, we started having the same problems again. They weren't exactly the same. They were a bit different. We had tests for Mpox. You could get tested at a public health laboratory. That was something that existed. But what we didn't have was sufficient capacity in terms of where patients were located. So clinicians couldn't just order a test. They had to spend hours on the phone with the health department trying to convince them to get their patient tested and then figure out how to get the specimen to that laboratory, as opposed to using the regular clinical laboratories that, clinicians usually send specimens to. And we heard for, a fair amount of time that, well, we could do 7,000 tests per week, and we weren't using nearly that kind of capacity, as though that indicated we were fine on testing. We weren't fine on testing. The tests weren't where they needed to be. So that was actually the wrong question. It wasn't how many specimens are you capable of testing per week. It was, are the patients who need to be tested getting tested? And are those results getting back to the clinicians in a timely enough way to inform patient care and to support public health action? So that's my long-winded way of saying that it was very clear that the questions we were asking about establishing testing in a biological emergency weren't the right ones. And it was very clear that the decisions that were being made about testing weren't nearly nuanced enough for what the emergency required. So we created a testing playbook for biological emergencies as a way to support decision makers who may be in the very hectic circumstances of responding to a biological emergency, to help them think about testing in a more nuanced way. It's published on our website. Actually, it has a standalone website as well called Better Testing Now, whereby we basically try to outline what the testing requirements might be at different phases of a biological emergency in a way to make it clear that not all tests are the same and they don't do the same thing. And some tests are needed more at different points of an emergency than others. But just to kind of provide that background for busy decision makers who may have very limited understanding of testing, and certainly in an emergency may have not enough bandwidth to truly kind of, tease apart all of the very nuanced layers of what goes into standing up and scaling testing in an emergency.
Do you have any idea how many people have downloaded and read your report?
I don't. I do know that it was being used in the White House in subsequent emergencies. So that was
Excellent.
gratifying. We've gotten a lot of great feedback about it. We call it like sort of a living document, and there's a place to submit feedback if we've gotten things wrong or if we missed something. It's just meant to be sort of a repository of more detailed thinking. We do get a lot of reference to it, and have been able to speak to industry and other groups about it. So that's been gratifying. But it's really meant to be a resource for the community, and if others want to take it and improve it or make second iterations of it, we would very much welcome that. I can't imagine going through any biological emergency in which testing isn't going to be a key, if not the key issue. And so it's really critical that we get this right.
One of the things that we perhaps not discovered, but noted in doing a prior project a couple of years ago with the WHO Pandemic Influenza Preparedness Group is a lack of understanding about use cases. How are the tests going to be used, and how do those use cases change during an outbreak or a pandemic?
Yeah. Use cases are key. I mean, first of all, you have to start with the use case and then figure out what kind of technology or approach is needed for that use case. And I think part of the problem when we talk about testing is we usually start first with the technology and then say, here's a thing, let's use it, as opposed to, what are we trying to do? What kind of information do we need? And then what tool or what approach is best suited to provide that information? So just to say, I am a big fan of doing these analyses. That said, one of the things I've been noticing in conversations, particularly when it comes to different types of testing approaches, and I'll just flag one as an example, is wastewater testing. There is a perception that the use case doesn't exist. And I have found instances in which there actually are use cases. They're just not recognized as use cases. So let me give you a specific example. I think there is a perception, wastewater testing not new, but certainly became more prominent during COVID-19. And during the pandemic, particularly when we had great new home-based testing approaches available, people started using those tools. They had a number of advantages important for public health. But one of the downsides of rolling out those tests was that our public health surveillance started to erode, because if people are no longer getting tested in doctors' offices or at laboratories, then public health agencies weren't going to collect the information. If you're testing at home, chances are nobody's going to know that test result except you or your family. So it doesn't go into public health. Now, the right response to that is not to say, well, then we shouldn't have home tests, right? Because clearly there are lots of benefits to people being able to test themselves in the privacy of their own home and get those test results immediately to inform decisions about whether they could go see their vulnerable loved ones 15 minutes later. But we, of course, also need public health surveillance. We need to track the virus, understand if it's changing, understand if it's getting worse or if the situation's getting better, to try to understand spread. There's a lot of different pieces of information we need that public health surveillance helps to answer. Well, wastewater testing was kind of rolled out as a way to perhaps kind of supplement some of what was being lost in the transition to home testing. And what wastewater testing did was it kind of gave us a sense of, is COVID out there? And sort of how much? Is it getting to be more, or is it getting to be less, and where? And that's different than what we call in public health line level surveillance data is. It doesn't tell you who tested positive and where they live, but it gives you a bigger impression of what's going on in the community. And I think some people in public health might say, well, that's not really specific enough for it to be useful to us. And I would just say I actually disagree with that. I agree that it is not specific as the other types of information, but it actually can be quite useful. It is useful to know if the situation is getting better or is it getting worse, how it compares to historical trends. It is useful to tell people when the season is starting and if incidence is starting to pick up or if it's starting to decrease. People use that information to decide whether they're going to travel or gather with loved ones, etc. It is also useful to prompt a deeper investigation of other data sources, right? So if you see the trends changing in ways that you don't expect, then it helps you go out and either look at other data sets that you have and try to look more closely at them, or potentially to collect more information to try to maybe do some more active testing approaches to see if something else is happening. And crucially, I think the biggest value that wastewater surveillance has provided us is that it's far less biased than some of our other public health data streams are, because there is often something different about people who show up in health facilities to be tested than people who are just in the community who may have COVID, and then that positive hit will be found in the wastewater. So wastewater is a less sort of biased sample in that way. So it's not to say one type of data is better than the other. In epidemiology, you're always kind of combining signals from multiple data sets to try to triangulate your way to the truth. And I think that surveillance approaches, it is really important to understand what the use cases are. But I think we sometimes in public health take too narrow a view of what a important use case is and how we use the information. And I think some of that comes from a tendency in the field to, of course, understandably want to protect resources and say, well, is it worth it to spend the time and the money collecting these data if I can't do X, Y, and Z with it? And I think those are fair questions, but I also don't think that is those are the same questions as, well, if it can't tell me everything, then therefore it is not useful.
Right. Isn't it really much more of a population screen as opposed to individuals? We think about wastewater.
Yeah, absolutely. Which, there are population level interventions, and I think sometimes we don't remember that. Maybe another example to give you is avian influenza H5N1. We don't really think people are rarely getting H5N1. I think that is, we don't have great surveillance for it, but I'm pretty confident that it's still a rare human infection. So it doesn't necessarily make sense to go out and testing people for H5N1. And certainly we don't, we don't have an easy way to do that right now. There are still some obstacles to that. But wastewater testing has been helpful for us to understand the timing of when this virus shows up in our communities, which can be useful for farmers to think about enhancing biosecurity biosecurity and occupational protections on their farms. It can also help us better understand the sort of seasonality of this virus. And then it can perhaps prompt more intensive active surveillance approaches like, reflexively subtyping flu A positives that turn up in health facilities if we think that there might be more reason to think someone has H5N1. I think those are important use cases. It's not the same as the use case of directly testing a patient for H5N1, but it is still, I think, a useful use case.
Yeah. But besides the types of tests we've talked about so far, what are the sorts of things you think might be useful? People talk about using perhaps eDNA, sources of spillover, wild animals, domesticated animals, etc.
First of all, and maybe we could just take H5N1 as a very specific example. There's so much we don't know. And better understanding the answers to some of these questions would help us greatly understand how much a public health threat it is. We've been afraid of this virus for more than 25 years now. It has been on the top of our list of pathogens of concern for a potential causing a flu pandemic. There's a lot of effort that's gone on over the last 20 years to prepare for an H5N1 pandemic, including the stockpiling of vaccines targeting H5N1. So a lot of investment has been gone into this, and we know so little about this virus. Right now, there's a whole lot of H5N1 out there. It is devastating poultry farms across the US. It might also be on dairy farms. I think the surveillance there is a little less clear, given that the virus is less lethal to cows. It's harder to miss in birds, and there's incentives for surveillance in birds that don't exist for cows. But there's a whole lot of H5N1 out there. We know people can get infected, and we know some of the people, historically, people who have gotten infected, about half of them have died. Recently, the infections have been in the US anyway, and this is a giant question of why it's just been in the US. Recently, the infections have been milder. But why that is, we don't know. There's some really interesting scientific hypotheses that center around prior infection with an H1N1 virus, which is what caused the 2009 flu pandemic. But that's hard to, fully understand the significance of. We don't know who's protected, who's not, and how much protection everyone gets. So it's critical that we better monitor and track this virus, because it can help us understand things like, why is this virus suddenly showing up so much? What is the timing of it? How are people getting sick? Are they getting sick while milking cows? Are they getting sick while culling the infected birds on poultry farms? Are they getting sick from their cats at home? Where are these cats getting the virus? Are they getting it because they are farm worker owners, are bringing home dirty, soiled clothes? Or are they catching birds in the backyard? We don't really know. And answering these questions could better help us understand how much of a threat this virus truly poses, and crucially, what do we do to mitigate it if we think it is a threat? Now, people might say, well, it'd be nice to know all these things, but, who really cares? Well, we've already cared. We have spent literally billions of dollars in responding to this virus over the past 20 years. It is a economic devastation for poultry farmers. It has certainly harmed dairy farmers as well, although not to the same degree. So it is not going away anytime soon. So better monitoring this virus in different populations and the environment could greatly enhance our knowledge and inform a better use of our resources for protecting our health and our economy from H5N1 and to make sure it doesn't become a pandemic. I refuse to believe that farmers don't worry about this virus, and they don't want to protect their animals, and they don't want to protect their farm workers. We've been doing some projects where we've been interviewing some ag professionals, including vets, and they're very worried about H5N1. They've tended, first of all, they see what it does to birds, and they know that this, will kill at least 70% of the flocks, and that is a devastating loss for the farmers. They have seen what it does to the cows, and the economics of that situation has only been ameliorated by the fact that if a dairy cow gets too sick to produce milk, it can be sold off for beef and retain some profit because the cost of beef is so high. But that doesn't minimize the devastation that the farmers feel of having to do that. I have to believe that the farmers want to do what's right by their workers and their animals, but they don't have the tools to do that. And so when you ask me what's needed, I would say we should be giving them the tools to be able to do testing on site so that they can make decisions about, either cohorting or isolating their animals or encouraging their workers to seek medication that could prevent or treat infection. But we haven't given them the appropriate tools. All we have given them are very weak responses to dealing with the costs of the situation. So basically, we've turned H5N1 into just a problem for them with no tools to help them be innovative and solve it.
So, as opposed to responding to a new pandemic once it's here, how do you think about the path to pandemic prevention? In your recent YouTube podcast, you stated changes in our activities in the environment are giving rise to new threats that could lead to new outbreak situations.
Yeah.
How can an outbreak be contained before it becomes a pandemic?
Here's what we know. First of all, pandemics have happened regularly throughout history. And I think that's surprising to people, but we had 3 naturally caused influenza pandemics in the 1900s. You've heard of one of them, 1918, that was the Great Influenza, but there was also some later in the century as well. And when you look back through history, pandemic influenza even, happened regularly. There's some indication that something that was once an old influenza pandemic might have been a coronavirus pandemic. So based on the historical data we have, we know that pandemics happen regularly. We also know that outbreaks of new diseases we haven't seen before, are becoming increasingly frequent. And this has been a steady increase since the 40s, possibly earlier, but most clearly we see it since the 1940s. And a lot of this has to do with changes in our environment and changes in our societies. When they've tried to understand, well, what makes new diseases emerge, we see a few things. One is that most new diseases come from wildlife. So most new human diseases come from wildlife. So they start in wildlife, and then there's undergoes some kind of change such that it can infect humans, and then to go on to cause an outbreak, to be able to spread between humans. When you look at what is associated with that spilling over from wildlife to humans, probably the single biggest factor that's been identified is land use change, which, if you think about it, makes a lot of sense. It's changing the likelihood of our coming in contact with wildlife. Also, changing the land can increase stress on wildlife, which can encourage the spread of wildlife pathogens. But land use change is important. Climate change is also part of that. So the data we see is that we're going to have more outbreaks of new diseases. All these outbreaks don't all go on to become pandemics. Some of them won't. It's just something, they're limited by the biology of the pathogen, that it doesn't spread that easily to be able to go on to become a pandemic. H5N1 right now does not have the ability to spread between people, and therefore cannot cause a pandemic. Pandemic talks about global spread. But they can. And the fact that they can, and that we're having more of them, means that there's a good chance we're going to have more pandemics absolutely in the future. So the way that we stop that from happening is, first of all, reduce the selective pressures that make the wildlife diseases jump to people. And that's where the land use change, and also trying to better understand what factors make that more likely to happen. So conservation efforts and other things dealing with the role that climate plays in changing disease spread, all of that is really important for preventing pandemics by preventing those outbreaks of new diseases that can spread. But then, crucially, if an outbreak does happen, being able to contain it swiftly so it doesn't spread further or allow the virus to continue to mutate and move along. And that's one of the reasons why we continue to talk about H5N1 with alarm, is that the more this virus copies itself in species, particularly in humans, we're just giving it more opportunities to figure out the right combination of mutations that can make it easy to spread between people. And so containing outbreaks swiftly is really important for stopping those outbreaks at their source so they can't spread. And if the pathogen isn't already capable of it, not giving it a runway to become better able to spread between people.
What are some of the ways that we can do that?
Well, I mean, surveillance, I think, is really key. And probably the single biggest thing we can do is to detect when these events happen earlier. And the more information we can gather on it, the better able we are to understand what to do about it. So let's just, take maybe a few examples. Let's say COVID, for instance, right? I gave the example where when COVID started, there were a few clinicians who saw that there were these unusual number of patients with an atypical viral pneumonia. So they saw evidence that the patients were sick with what looked to be a viral infection, but they didn't quite know what was causing it. If we were able to know quickly, and we did know relatively quickly, but there were unfortunate delays, and some of that was due to political intervention. But if we had known swiftly that it was a new coronavirus, which turned out to be, the entire world would have known at that moment that this was headed to be a pandemic. Because respiratory viruses spread very, very easily. And when you don't have immunity to it, it's easier to find everyone's susceptible to it. So, instead there was, some debate. And then even when we found out that the virus was spreading between people without necessarily very close contact, there was still some debate over whether it was a pandemic. Listen, we have to respond to the worst case scenario to prevent the worst case scenario from happening. So I think the testing is key. I also think that other types of characterization approaches are important. So one thing that we don't do enough of in responding to these outbreaks is genomic epidemiology. It's not possible for all pathogens, but it is more possible than we avail ourselves of. Trying to understand, genomic analysis of pathogens can, in some instances, help us link cases so that we can understand who gave it to who. And analyzing that can help us better understand how it's spreading. And then once we better understand how it's spreading, we can then act to prevent it from spreading. So I think there's a lot of things that we can do there. Obviously, I think depending on the pathogen, what other approaches we take will differ. Again, if it's a respiratory pathogen, I think we've learned a lot about the importance of indoor air environments as creating conditions that allow for super spreading. Obviously, preventing super spreading is a good way to prevent a pathogen from becoming, a pandemic. So the surveillance piece is really important. And I view the surveillance as not an end. It is a collection of information that inform decisions about how best to act and to act in a most targeted, most effective way, as opposed to what we wound up having to do in COVID, which was we didn't know where the virus was or how much of it was happening and how bad it was. And so we had very blunt tools like shutting things down. Which is not a great response. I mean, it's just not a great response. It's like using a sledgehammer when really we should have been using a scalpel, but we didn't have appropriate insights and data to know how to use a scalpel.
This episode of Halteres Presents is brought to you by the UC San Diego Division of Extended Studies, where courses are designed for professionals looking to deepen their expertise in the biotech space. Their core course, In Vitro Diagnostics Product Development, offers a practical end-to-end look at taking an IVD product from concept to regulatory approval. You'll learn about product requirements, assay development, instrumentation, risk analysis, and key clinical and regulatory considerations. You can also broaden your skills with their Precision Medicine and Companion Diagnostics course, which covers biomarker-driven development, the co-development of companion diagnostics and therapeutics, and the expanding role of precision medicine. Ready to get started? Use our exclusive discount code HALTERES10 at checkout for 10% off the price of your enrollment. That's code HALTERES10 at checkout for 10% off. For links and to learn more, scroll down to the show notes for this episode. Advance your diagnostics career with UC San Diego Extended Studies. Your next step in biotech starts here.
What could have been done in the case of China? Should people have been testing those live animal markets?
We shouldn't have those markets. Now, I don't want to just single out those markets. Like, there are some agricultural operations that are also, breeding grounds for diseases as well. But the confluence of live wildlife and humans in very close quarters is just asking for disease spillover events.
Right.
But testing, of sure, but would we have even tested for a novel coronavirus before we know it? I mean, I think the challenge is those markets have proven to be challenging, and possibly also, why we had the first SARS event in 2003, that the markets also may have played a role in that as well.
Would we have been able to know from the genome of a new coronavirus that it was likely to infect humans?
Yeah, I mean, I think it's hard to know that. It's not to say that that isn't an area of ongoing science. It's been sort of hard to extrapolate from genotype to phenotype, but certainly I think knowing the sequence of the pathogen automatically told us this is something we haven't seen before. And we had the epi data to say that, well, there were people who were getting sick that didn't have a connection to each other. And that's highly suggestive of the fact that it is spreading. And then you assume that the worst case scenario until you have enough evidence to prove otherwise. And I think that's one of the things that we have a hard time doing in public health. We are somewhat of a retrospective field, where we like to look back on the data that have been accumulated and say, well, we haven't seen a signal yet, so it's not going to happen. And I think we actually need a change in strategy, which is, what do we need to do today? Like, what is the worst case scenario? And then what do we need to do today to prevent that from happening, or to be ready in case it does? And that's a way of thinking that public health needs to get better at doing. I have colleagues that work in the national security space, and they are much more used to thinking in those terms. And I think kind of bringing those two disciplinary approaches together, I think are really key. We actually have a project ongoing called Biosecurity Game Changers. And one of the things we're trying to do is train sort of the next generation of leaders to be thinking in that way, to think, how do we lean in now to prevent worst case scenarios, and to equip them with skills to not only be able to ask those questions and to take those kind of decisive early actions, but also, to get the political leaders to kind of buy into that and to have an effective response, recognizing that, sometimes it means acting before all the evidence is available, but also being humble about the fact that, sometimes you have to take an early action and then work like heck to collect the information to make sure that what you're doing is appropriate and that a change of course isn't necessary.
Jennifer, with that thought in mind, we know coming out of the pandemic, unfortunately, that well-established, well-known serious diseases around the world have had significant setbacks in terms of disease management control. TB is one where it's widely held that the TB programs have been set back over a decade. We're seeing that even impacting the United States in the case of tropical diseases like Zika and Chagas and dengue, making inroads into the country. We've noticed that even with non-infectious diseases around maternal child health, the metrics there are looking much worse over the last couple of years than they had, coming into the pandemic. With those thoughts in mind, and your let's look forward approach to public health, how is that influencing some of the efforts and programs maybe you're thinking about in terms of new surveillance opportunities in the United States, again, under a One Health type umbrella that may be impacting us that in the past did not?
We have to stop thinking so much in terms of specific diseases and conditions. Obviously, the specifics matter. But when you see TB roaring back, when you see new diseases emerging and starting to spread in areas that you've never seen them before, when you see measles threatening the elimination status of multiple countries in North America and other countries around the world, it is a symptom of the fact that our systems are not working, that our systems have broken down. And the pathogens are exploiting that breakdown. And I actually did my doctoral thesis on tuberculosis, so it holds a special place in my heart. And when I finished it, I remember a very seasoned public health expert said to me, if you know TB, you know public health. And it's true, because when you think about what it means to kind of prevent, detect, and respond to TB, you think about the actions that are taken. Those are actions that are very relevant to a whole host of diseases and conditions, right? Thinking about making sure a patient gets an early diagnosis, isolating an infected patient, possibly, finding who they have exposed, who may need monitoring, and possibly quarantine until we know for sure they're not infected, or at least offered some kind of testing or treatment. Thinking about the laboratory systems and the pathogen specimen transports. Those are all capacities that are reused for a lot of other things. So I like to think less pathogen specific and more capacity focused, and to think through a range of health issues and think about what do we need to do to prevent or respond to these issues. And when we see the signals in multiple different disease outcomes, what it's telling us is those capacities have eroded, right? And so, we have to focus again on these capacities and less about, single use responses and more about ongoing sustained approaches. And for some reason, we haven't done this well in public health, or particularly in infectious diseases. And it's partially, I think, how money has flowed. It's episodic. It's awarded after an emergency, or it's awarded to like a particular vertical program. Like that has been historically the approach. And I try to liken it to, things that make more kind of day-to-day sense to people, like thinking about, if we funded fire protection the way we fund public health, we would have had like this enormous fire, and then we would go around dismantling all the fire detectors. Okay, well, the fire's over. We don't need these anymore. Let's get rid of them. We don't need the smoke alarms or the signs telling you where the exits are. We definitely don't need to conduct fire drills because that's over, So I don't know why we haven't done that with infectious diseases, but also, again, like a lot of these tools we're using have multiple benefits, even if they're funded with one vertical program, right? The laboratories that process the TB specimens, or the laboratories that process other things, the specimen transport funds different things. And by the way, the next time a pandemic hits, that specimen transport network that you just built because you had a TB problem is exactly what you're going to be tapping. Those, public health nurses that go out and do dots are exactly the ones that are going to be tapped to do contact tracing, the ones that have those skills. One of the things that really spooked me was just prior to the COVID-19 pandemic, we published a paper where we had analyzed the US response to measles outbreaks that had happened 2017 to 2019. In 2019, the United States came within weeks of losing its measles elimination status due to ongoing local transmission of measles in 2019. And we miraculously got it under control with like weeks to spare. But I had been interviewing the health departments that were involved in responding to measles outbreaks. And what was really stunning to me was how few resources they had to deal with measles outbreaks. Measles is an incredibly transmissible disease. It is sort of like the poster child disease for thinking about contact tracing. If someone's been exposed to measles, you want to know who those people are, make sure that they too don't have measles, make sure they, stay home until we know for sure they're not going to develop measles and give it to somebody else. But what we found was that health departments were unable to do things like contact tracing because they just didn't have the resources to do it. What they would often do instead would, put out a press release that would say, if you've been at this place within these, this time period, go talk to your doctor about measles. And, clinicians weren't necessarily equipped to deal with that. They didn't know what to say to their patients. They didn't necessarily have the tools, et cetera. But also, we were basically pushing onto the healthcare system, which was in no way equipped to really deal with that, or very hard to deal with that, what was ultimately the responsible of a public health response. And you might say, okay, well, whatever, we got measles under control in 2019. Why did that matter? 2020, COVID hits. What do we see other countries around the world doing? Other countries around the world able to use, instead of broad damaging shutdowns, what they started using was case-based interventions like rapidly testing, isolating those who test positive, identifying their contacts, quarantining their contacts, doing contact tracing. We weren't able to do that as a country in early 2020 because we didn't have the resources. Congress then appropriated emergency sums, and health departments around the country scrambled to hire contractors to do contact tracing. But let me tell you, that's more of an art than it is a science. And you can't just suddenly try to stand up that capacity. You could try, but it's very hard to do that effectively in the midst of an emergency with people who have never had experience doing that. So, that's my example for why you build these systems and you have to maintain them, just like you always check the batteries on your smoke alarms every year. You don't know when the next fire is, but you're pretty sure it's going to happen, and you want to be sure to know when it happens. So that's why we keep these systems going.
You mentioned very early on, and thank you for that, this concept of One Health. We're wondering, is there an entire new chapter for people who were never alive to understand the impact of some of these infectious diseases around polio, for instance, and stuff that we could face now because all the countries around us, because of the PEPFAR in USAID funding cuts, lost surveillance programs, funding was diverted, then it's gone back again, funding silos, all the things you could think about. On top of where we are today here, it seems the doors are wide open for some potential issues. And I don't even know how you can even get up in the morning knowing some of what's potentially out there. It must be so daunting.
You know what I'm really worried about? I mean, I'm worried about all those things that you mentioned. I'm just not sure those are the motivating examples.
Okay.
They should be. But it's hard to get people to take the fear of polio seriously, especially since, they can still get vaccinated if they want to be, right? The United States is going to be hit with a biological attack. I have never been more worried than I am now. And I told you, I got my start in this field after September 11th in New York City.
Yeah.
We were very worried about being attacked. We worked very hard as a nation after that to reduce our vulnerabilities to a biological attack and in turn deter a biological attack because we were more prepared than we had ever been. But we seem to be systematically dismantling all of the protections, which not only makes us more vulnerable to an attack, but after a certain while, it almost becomes an invitation.
Mm-hmm. Well, you mentioned that already, the invitation to the pathogens to come on in. So it's just the extension.
And the world is not any more stable. It is there's far more upheaval in the world now than I feel like there had been. There are just many more actors on the scene. We already saw during COVID that governments were sowing disinformation about COVID and COVID vaccines for political purposes. So the use of these events for political purposes is already been demonstrated.
Yeah.
One system that has been recently dismantled, which is a system I've not been a huge fan of, the BioWatch program. This is the the air sniffers around the country for biological threat agents. I think the system has not proven itself in the ways that one had always been hoped. Nonetheless, it was a system that was operating for a particular purpose. And it was just recently shut down, which, might have been the right approach. But usually when you just look at a surveillance system that's existing, particularly one that's meant to detect a very high consequence situation like a biological attack, what I think the ideal response is say, well, if this isn't quite it, let's work on developing what is quite it. And then once we have that in place, take down the one that isn't it. We didn't do that. We just shut it down. It was announced, it was made public eventually that it was shut down, and there's been no replacement. And that has happened at the same time that a number of other key systems have been shut down. With the government shutdown, the CDC has only basically been updating a couple of surveillance systems, but most of them just remain, the data are stale as of more than a month ago.
Yeah.
So we have a whole lot of blind spots that we are amassing and no real plans to try to increase them. And we have dismantled the protections that have existed overseas to prevent these events from happening in the first place and from coming over here. So there's just a lot more vulnerability in the world, and ultimately as an American headed towards us potentially, than we've had in really, I don't know for how long.
I've comforted myself to some extent, perhaps stupidly, that people would be hesitant to have a biological weapon because they'd be impacting their own population as well, ultimately.
One could hope, but hope's not a strategy. I mean, I don't know. I mean,
Yeah.
I really don't know. I mean, I was thinking about the last time there was an official US statement. I mean, at one point, and I'm not a national security expert, at one point, the deterrence for a biological weapon, I remember during the Bush administration, George W. Bush administration, it was stated that we would respond if a country hit us with a biological weapon with a nuclear attack. So the consequence of these events is could be quite considerable.
Yeah.
I don't know. I mean, I'm just looking at a lot of the ongoing conflicts in the world, and it seems like the governments that are involved in those conflicts have been incurring lots of collateral damage and harm to their own civilians in the process. And so that doesn't make me quite feel hopeful about that as a deterrent for a biological event.
Jen, we live in a country where people have multiple sources of information about healthcare,
Yeah.
much of which is based on erroneous or poor assumptions and data. Upon occasion, we all find ourselves engaged in conversation with people that are tragically and I think often unknowingly misinformed. What are your observations about how we should communicate with our fellow citizens about these things?
Yeah. I mean, I have never seen as much willful spread of false information as I have since the start of COVID. And it's really, I think, been aided by the rise and dependence on social media as a key source of information. I mean, in public health, there's this glib statement that you're only get your information from trusted sources. I mean, it's kind of a pointless thing to say because people get their information from social media, period. Media outlets, traditional media outlets, a lot of them have paywalls, so I don't know where people are supposed to get news. Government agencies are not particularly great at communication. They've been late to show up to social media. They don't really know how to use it appropriately. And even if they use it, they can't at all compete for the attention that skilled influencers with huge networks that then earn them dominance in the algorithms of social media. They can't compete. They don't even show up on someone's feed. They can't get in front of the eyeballs of the American people. So I think that it's a very difficult time to be alive and to even do your own research, as people are often encouraged to do on social media, because depending on who you are and what your algorithms have fed to you, the outcome of that research may be very heavily biased. And one example that I just like to talk about is during COVID, I had gotten a question from a very senior person who asked me, a former government official who had asked me, a question about COVID and why wasn't the FDA allowing the use of what was clearly demonstrably a cure for COVID. And it was not a cure for COVID. In fact, it was something that were someone to take would have harmed them quite a bit. It wasn't even the ones that have been in the news. It wasn't hydroxychloroquine or ivermectin. It was something totally else. But I thought to myself, well, this person is asking me this question. This person who should be well connected, be able to understand, like, why was this person even doubting the intentions of the FDA? Former government official know that, anyway, I thought if that person couldn't figure it out, then what hope does the average person who doesn't have as much understanding of how government works and what sorts of informations are out there, et cetera? So it's really, really difficult. There is just so much inaccuracy out there. And there are people worse than just being, people casually spreading inaccuracy. There are people out there who are making millions of dollars intentionally spreading lies in recognition of the fact that lies spread faster and farther on social media than truth, and that the way to make money by getting more clicks and likes is to be more outrageous. It's really hard to compete when you have an information economy that is driven by that central premise. So that's really, really tough. I think, where does that leave us? I think two things. One is that we as communicators, we as experts, people who know anything, we have to engage with these communities. And so one of the things we've been trying to do is to compile a list of influencers that we think provide reasonable, accurate information. So instead of telling people, like, don't get your information from social media, say, here are some accounts you should follow. That's one thing. We obviously still continue to engage with traditional media. I think it's important because there are other outlets for that information, but you can't only engage with traditional media. I think it's important to work with influencers. We are in an unfortunate situation where it's unclear to me whether health agencies are going to be able to be the source of trusted information. There are some deeply concerning developments regarding vaccines in particular, coming out of vaccine-related information coming out of CDC and HHS. And I think many people are understandably turning away from those places as the source of trusted information. There are other sources that are organizing. There's something called the Vaccine Integrity Project that colleagues at University of Minnesota launched to try to be a source for evidence-based information about vaccines. I think that is really important. But ultimately, it takes all of us. And it takes all of us, not just in our professional lives, but also in our personal lives. The good news, if you could look at it this way, is that people are probably most heavily influenced by their loved ones, the people they know in their lives. And I think what that means then is that we have to work within our own families, within our own friend networks, and also within our own communities to make sure that the people that we know have the information that they need. And that kind of bottom-up approach has always been important, but probably hasn't been as heavily prioritized when we talk about like communication and sharing information. But I think it's absolutely critical. I think it's the only way we're going to overcome, the situation where the information ecosystem is just awash in lies being spread for profits. Until we have some regulation of that, I think we have to overcome it just in our own personal networks. People listen to the people they trust, and you trust the people that you know.
I feel like we've been going down a path of negativity all this time. Are there things that you're particularly optimistic about?
Yes, I am optimistic. I mean, listen, it's tough right now. There are a lot of challenges. The world is not where we want it to be. And the world is not where I would have hoped it would have been after how tough the last 5 years have been. But I am really hopeful. I mean, we've done some extraordinary things as a society, as a planet. COVID, let's just say COVID, it was terrible, but there were some important points of light. I think on the science, really incredibly inspiring stories that emerged, right? I mean, I'm a mom of 2 young kids, and I love the fact that I can now test my kids inside my own home, because the number of times I need to do that is too much to have to, drag your kids to the doctor every single time. I want to see more of that. I want more tools in the hands of parents to make it easier to do the very hard work of parenting. I want more tools in the hands of people who are now really inspired to take charge of their health. I mean, there's some real challenges with the rise of like the wellness movement online, and a lot of people out there trying to sell bogus cures and, to dupe people into, buying junk or even worse, harmful things in an effort to, improve their health. We could focus on that, or we could say, hey, listen, there's a whole bunch of people out there who want to take charge of their health. Now let's give them the tools, the real tools, the no kidding tools, the evidence-based tools to absolutely do that. As a public health person, like, that's incredible that we have people who are really motivated and trying to have the agency to do that. So I'm incredibly inspired by that. I know some people, pundits try to question it, but the mRNA vaccine technology is one of the greatest advances of modern medicine. And the number of cures that are within reach, potentially using those approaches, is just truly awe-inspiring. I mean, the fact that we might be able to use a pandemic invention to possibly help people treat their own cancers is just extraordinary. So I am really, really cheered by that. Obviously, I'd like to see us invest more instead of trying to retreat from that technology. But, people haven't turned their backs. I think there is a lot of interest. I think even Congress is trying to salvage some of the recent attempts to gut some of the funding for that. So that's another important point of light. And then finally, the thing that inspires me the most, and the thing that I feel most privileged about, is the fact that I'm at a university and I'm surrounded by young people. And let me tell you, the young folks are incredible. They are brilliant. They are kind. They are thoughtful. They are inspired. They are not yet cynical. They just want to use their lives to make the world better. And we just have to give them the knowledge and the tools to do that. But let me tell you, they're going to blow us out of the water. Like, the future is absolutely looking bright. These are people who all of us suffered under COVID. It was tough for everybody, but no more so than the young people. The kids who were kept out of school, who missed their proms, who couldn't play with their friends, the ones who forewent, important developmental milestones because of the inadequacy of our response. They live through it. They're permanently changed by it, but they are using their experiences to, make the world a better place. So, I feel very fortunate to be able to teach and interact with my students, and also to have kids at home and their friends. They're just so thoughtful and just interested in making the world a better place. And it is impossible not to be optimistic after, being around that and picking up on that energy.
That's great.
Well, Jen, this has been a very informative discussion, at times sobering, but also uplifting. Thank you so much for sharing your thoughts and enjoying our podcast today.
Yes, thank you so much. It was wonderful.
Thank you so much. It's a real pleasure to be with you both. Appreciate it.
Halteres Presents is produced by Halteres Associates, a US-based bioscience consultancy that provides strategic and tactical services in the areas of diagnostics, medical devices, and life science research to clients of all sizes. The views, information, or opinions expressed during the episode are solely those of the individuals involved, and Halteres Associates is not responsible for any errors or omissions, or for the results obtained from the use of this information. The information provided in this episode is for informational or educational purposes only, and is not intended or implied to be a substitute for professional medical advice, diagnosis, or treatment. Halteres Associates would like to say thank you to this episode's guest or guests, and thank you for listening to this episode of Halteres Presents.